Thank you very much. My name is Wataru Kimura. Thank you, Professor Lin, for inviting me to this wonderful Congress of IASGO 2021. Thank you, Mr. Chairman, ladies and gentlemen. My presentation is Diagnosis and Therapeutic Strategies for Intraductal Papillary-Mucinous Neoplasm, IPMN, of the pancreas up to date. COI, nothing. IPMN is conceptually positioned within cystic diseases of the pancreas. Cysts with lining epithelia are defined as true cysts, and those without such epithelia are defined as pseudocysts. True cysts are divided as non-neoplastic and neoplastic cysts, such as IPMN, MCN, SCN, SPN, and secondary cystic lesions. Ohashi et al. Published a paper of 4 cases of mucin-producing tumor of the pancreas, which have typical findings of the papilla factor in Japanese magazine in 1982. It is the first report of IPMN in the world. Dilatation of the orifice of the papilla factor, dilatation of the main pancreatic duct or its branches by images, such as MRCP or ERCP, and a fish egg-like appearance by pancreatoscope or endoscope are the characteristics. Histologically, papillary projection is also a characteristic of IPMN. In advanced IPMN, fistula formation with other organs, such as the duodenum, is sometimes found. In this slide, duodenal fistula is confirmed by ERCP. MRCP and endoscopic ultrasonography of branch type of IPMN are shown in this slide. Sometimes a protrusive lesion by EUS has the typical characteristics of IPMN, as indicated by red arrows. In this slide, massive mucin production is confirmed intraoperatively with naked eyes. This is very important for diagnosis of this disease. IPMN is classified into 2 types, main pancreatic duct type and branch type. Incidence of IPMN was referred to by Selboni et al. In Pancreatology 2019. Meta-analysis of 17 papers, 48,860 cases using MRCP, CT, and EUS are performed. Cystic lesion was found in 8%, and IPMN was found in 4.3% of the cases. With regard to the malignant ratio of IPMN, invasive carcinoma derived from IPMN was found 0% to 3% among 60 or 263 cases by the Uehara report or the data report when IPMN patients were followed without operation. Pancreatic duct adenocarcinoma, PDAC, with IPMN was found in 2.2% to 8.8% when IPMN patients were followed in 5 to 10 years, with reference of papers by either Tano or Kawamata. The main pancreatic duct type IPMN was found in 0.1% among 1,000 autopsy cases by the textbook of mine. In the textbook, IPMN was found in 5 cases among 1,000 continuously autopsied cases. IPMN was found within the pancreatic duct in 1 case, and patients died of cancer derived from IPMN in 4 cases. How to observe non-rejected cases of IPMN. First, international guideline in the journal Pancreatology 2017, follow-up according to the size of the IPMN should be necessary, and follow-up should be continued if the patients are possible to undergo operation. Second, in the European guideline in 2018, twice a year follow-up is required for the first year. After that, annual follow-up is required. Follow-up should be continued as long as operation is tolerable. Third, according to HGA 2015, follow-up once every 2 years is necessary. If there is no change in 5 years, follow-up should be stopped. With regard to malignant change in branch duct IPMN, 5.9% among 1,774 cases become malignant in 10 years by the report by Han et al. This figure feels considerably low. Following two revisions of the international guidelines 2012, 2017, and publication of other guidelines and papers, surgical indications for IPMN have changed to a conservative direction. Male-female ratio was 2:1, and the mean age was 65 years. In this slide, postoperative survival curves of the patients after resection of IPMN are shown. In our series, invasive carcinoma derived from IPMN is found in about 20% out of 128 cases with IPMN. The 5-year survival after operation in cases with invasive carcinoma derived from IPMN is about 60% with the Kaplan-Meier analysis. The results are not satisfactory when comparing the 5-year survival of 100% of cases with non-invasive IPMN. Therefore, the aim of the clinicians for IPMN will be, clinicians should operate the patients with IPMN with carcinoma in situ or non-invasive carcinoma. Dr. Takeshita in our group investigated Ki-67 of various IPMN. Percent of Ki-67 is significantly less in adenoma than IPMN with carcinoma in situ, invasive IPMN, or adenocarcinoma. Dr. Murayama examined volume of ductal dilatation of IPMN in CT scan. Ductal volume is significantly small in benign adenoma than other malignant IPMN. Dr. Takasu histologically divided IPMN into 4 subtypes and showed that pancreatic biliary type was worse prognosis than gastric or intestinal type. If invasive carcinoma derived from IPMN was investigated, the results were same, that intestinal type was better than pancreatic biliary type. First, this slide shows the natural course of branch type of IPMN in 74-year-old man, 3 centimeters in diameter in the head of the pancreas in 2OXX, which has an appearance similar to a bank of grapes in MRCP. This patient could not be operated in some reasons. 2 years later, in 2OXX+2, the patient needs a stent in the bile duct for the icterus and gastrojejunostomy for the stenosis of duodenum due to the invasive IPMN. This slide, the histology of invasive carcinoma derived from IPMN is shown. The arrows show the invasive parts. This slide shows the lower magnification of the former slide. There is IPMN adjacent to invasive parts. The further lower magnification of the invasive parts are shown in the slide. We understand that invasive carcinoma is derived from IPMN, not from the ordinary ductal carcinoma. We call such lesions the invasive carcinoma derived from IPMN. Colic stenosis was found in another case with pancreatic carcinoma derived from IPMN. The stomach is also invaded in cut specimens. The colon invasion and stomach invasion by pancreatic carcinoma derived from IPMN is histologically shown. The guideline 2017 cyst growth rate more than 5 millimeter by 2 years were added in worrisome features. The IPMN in this patient showed growth from 17 millimeter to 48 millimeter in 10 years, as shown in these images. I reported the significance of increased changes in cyst size of IPMN in hepatobiliary pancreas 2018. Increasing cysts have several meanings. Mucin is produced from an epithelium in the cyst. The branch that was communicating the main pancreatic duct was occluded for some reason, but the content did not leak anywhere. The communication between the branch duct and the main pancreatic duct becomes narrow. Mucin is viscous and does not easily flow. The production of mucin exceeds the outflow. This means that the cyst epithelium is capable of producing mucin more than a certain level. In addition, if there is an obstruction mechanism in the outflow pancreatic duct branch, it may be malignant. If it increases, even if it is completely occluded, it means that the epithelium still has the ability to survive and produce more mucin without losing the productive ability against cystic pressure that is increased by the occlusion. From the suggestion mentioned above, this cystic epithelium is neoplastic, yet active and resistant to degeneration. This means that it is thought to be malignant. It is natural that this was added in worrisome features. Japanese National Clinical Database pancreatoduodenectomy in 8,575 cases in 2011. The hospital mortality was 2.8%. This figure is published Annals of Surgery in 2014. So good operation is not to lose patients with operation. Post-operatively important things are being alive, eating, having no fever. Drainage is not only good for patients, but also good for surgeons. Preoperative attitude. Doctors necessarily make patients have the recognition that they will undergo severe operation and that shows strong intention and posture to fight the disease. I show the prevention of the post-operative pneumonia, walking practice before the operation, sitting straight position, breath for 3 pieces of bowl up, the practice of coughing out the sputum. My textbook. Thank you very much for your attention.